Can they see our chat?
No, but everyone can hear. So if you could put your mute on. I think we are now live. Okay, welcome everyone to this week's webinar. We're focusing very much on heart failure and very much actually in the central parts of London with our heart failure on central London CCG, West London CCG and Hammersmith, or the Tri-Borough. But this webinar will be applicable to all of North West London, so do join in if you want to understand how services are now changing and developing and becoming really integrated for our systems going forward. Lots of learning today and lots of really good speakers. This is a running order. First of all, we'll have Dr. Carla Plyman, who works at Imperial College London, specialist in heart failure, giving us the overview and how we can work together to improve those outcomes. And then Dr. Afsana Suffer and Dr. Simon Gordon, who probably don't need any introduction known to many of us, on again the new pathways across primary secondary care and that system one approach and how to get our clinical systems to really work for us to make patient care really integrated. And then we're really lucky to have a specialist nurse, Caris Barton, really helping us understand what we can do very specifically for our patients and using this new remote technology that's now come into the NHS over the pandemic to actually now affect really good high quality patient care for the long term. At the end of that half an hour, time as always for your questions and answers, but please do put them in the chat as we go along, and our speakers will be able to respond to the questions in the chat as well as at the end, and time some really interactive case studies. We hope to make this as interactive as possible. Of course, all the speakers and myself, you can hear our voices. We can't hear your voices unless you contribute in that Q&A in the chat, so please do. Handing over now to Dr. Plyman.
Thank you for that introduction. I'm going to thank you very much. So thank you for the invitation to come today. I have the easiest part of this talk and I will be as brief as possible. Although Imperial obviously sits within the Tri-Borough, I would like to showcase what we've done, and I think what we have done is something that can be repeated in other places. So we have an integrated service in Imperial. We work closely with our primary care colleagues. COVID has forced us to become even closer. We've taken that opportunity to redesign our entire pathway across the heart failure service, from patients presenting in the GP setting all the way through to end of life. So we will take the opportunity to do some heart failure teaching, but we're also going to take the opportunity to show you what we've done, how that's worked and how we think it will improve things going forwards. So if we can go to the next slide, please. So very briefly, what is heart failure? Heart failure is a clinical syndrome. The heart isn't working well enough to get blood around the body, requires symptoms and signs, but also evidence of significant cardiac dysfunction. So we will always want to do an echo. Comes in lots of different shapes and sizes, and it's only becoming increasingly complicated as we get better at diagnosing and better at imaging. Breaks down into 3 or 2 standard groups: heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Both do what they say on the tin. Heart failure with mid-range ejection fraction came into being 4 years ago. It will disappear from being later this year because most people just find it confusing. So I would ignore that it's there for the moment. HFrEF and HFpEF. HFpEF constitutes a wide variety of problems. Next slide, please. So heart failure is very common. That's why we're all here today. There is an overall prevalence of about 2% in the UK population. I apologise, I have messages coming up and beeping and I can't get rid of them from another group. Heart failure is very common. It becomes more common as patients get older. So in the over 85-year-old cohort, 15% of patients are thought to have heart failure. We have an estimated 200,000 new cases in the UK every year, and it's expensive. It's very expensive to care for heart failure patients. It's estimated that the year before last, heart failure admissions cost nearly £400 million. Caring for heart failure in primary care is actually very cheap. It's the heart failure admissions that cost the money. So bringing patients into hospital, having them come into A&E is where most of the expenditure for heart failure sits. And that's important because actually 5% of all hospital admissions are for heart failure, and that's all admissions, and that's a huge amount. And heart failure is only going to become more prevalent. I think this is a way of telling me to speed up.
Oh, no, sorry.
No, sorry. So heart failure is becoming more prevalent. So things are really bad at the moment, and they are going to get worse. We are all surviving our heart attacks. We're all getting much better at surviving cancer, but the cancer drugs are causing heart failure. Lots of other things are causing heart failure. Heart failure is going to become incredibly common, and we need to work out how to care for these patients better. If we go to the next slide, I'm very briefly going to say that actually heart failure is as important as cancer. It's as common as many types of cancer, and the prognosis is bad, if not worse, than many types of cancer. So patients diagnosed today with heart failure have a 50% 5-year survival, which is pretty awful. Every time a patient gets admitted into hospital, they have an 8 to 10% chance of dying during that hospital admission. So actually it's an incredibly morbid, and it has an incredibly high mortality, despite the fact that there's a presumption that it's relatively benign. If we go to the next slide. Thank you. So what about our diagnosis and prevalence? So this was a study, an interesting study done very recently by Pumping Marvellous. So only 7% of patients are diagnosed in primary care. It's probably fair enough, to be honest. But 75% are diagnosed in hospital during a hospital admission. So for 75% of patients who go on to get a heart failure diagnosis, 75% of those are diagnosed in hospital and not outside of hospital. This is important. 24% of patients who are admitted to hospital die within a year of their admission, and that is also recognised. There is a 30% 1-year mortality from heart failure. Very few patients said that their GP ordered a blood test for heart failure, and this is relevant. We won't have too much time to go into it, but there is a very simple blood test, BNP, anti-proBNP, that can very effectively rule out heart failure in the community. When patients do come into hospital, their admissions tend to be protracted. They take up a lot of bed days. They tend to need a lot of medications. And if we try and expedite their discharges and send them home soon, there's a lot of evidence to show that if we do that, these patients are more likely to be readmitted. So when they do come into hospital, they spend a long time in hospital, and their mortality during those admissions is high, and their mortality within a year of that admission is also very high. Next slide, please. And press, if you just press forward again. So this very briefly just highlights what I'm sure everyone knows. Heart failure is incredibly comorbid. It's not a very simple thing to treat for many reasons, but not helped by the fact that we have to link in with various other long-term conditions. This is where primary care sits and is really integral to helping with all of this. The vast majority of patients, so I think that most of our patients have at least 4 other comorbidities, and on the right here is a list of what those are, and they are what you're going to expect. So I'm not going to go into any more detail. Next slide, please. So very briefly, heart failure with reduced ejection fraction therapy. If you go on to the next slide, there are long established drug treatments for this, and it's really relevant, and I'm not going to go into detail aside from the fact that if patients with HFrEF get onto prognostic heart failure medical therapy, their mortality is halved. So there is a 50% reduction in mortality. So it's actually got more evidence base, and it's more effective than chemotherapy is for cancer. And that's really important to know. I've added SGLT2 inhibitors small because we now know that they are licensed for heart failure, and in addition to standard therapy, they reduce mortality and hospitalizations. But again, this is not the forum to discuss that, but it's just to make a point of it. If you go to the next slide, again, ramming home the point that it's also not just the case of it being 1 drug or 2 drugs. You have to be on all of the drugs. It is a cumulative effect of the drugs. So it's not just the ACE or the beta blocker, it's the ACE and the beta blocker and the MRA and the SGLT2 inhibitor. And that's what this slide shows. If you manage to get onto more drugs, your mortality is decreased even further than if you only manage to get onto 1 or 2 drugs. Next slide, please. HFpEF, easier to talk about at the moment. There aren't any prognostic medications. That largely reflects the fact that HFpEF is a hodgepodge of diseases. We are increasingly trying to tease out the different strands of HFpEF, and that's most evident, for example, with amyloid. Amyloid cardiomyopathy, very rare, but it is classified as HFpEF, and we now have effective treatments for TTR amyloid. I suspect SGLT2 inhibitors will revolutionise HFpEF, and I strongly suspect they'll be the only drug to show prognostic benefit in most patients with HFpEF, but I've yet to prove that. We will see patients with HFpEF, but largely to give them, to diagnose them and to give them advice so that they can then self-manage in the community. Next slide, please.
Thanks. And can I ask actually, Dr. Clement, is there any particular SGLT2 we should be using? Because always, as GPs, asked to start prescribing them, but it's a new sort of area and indication for us. Is there one you'd recommend, or is it really?
So it's at the moment, it's slightly difficult. The only one licensed for heart failure without diabetes is dapagliflozin. So if for heart failure without diabetes, you can only use DAPA at the moment. That is going to change because for EMPA there is evidence, so that will change. But at the moment, if you do not have diabetes, it will be dapagliflozin. If you have diabetes, then you can take your pick.
Fantastic. That makes sense. That's really helpful. Thank you.
So Midway Summary, if I've not been clear enough, heart failure is very common. It can carry a very poor prognosis and it's comorbid. It can be complicated to look after. For HFrEF, we've got a large cohort of drugs that we know work and they work effectively. We also know that many patients with heart failure are diagnosed late, and that means they are more likely to come into hospital, they cost more, and they are more likely to die earlier as a result. So that's the target area. This is why we're part of the reason we were looking at pathway redesign. Next slide, please. Okay, and next slide. That's kind of given. So very briefly, I just wanted to look at some of the London data. So if we go on to the next slide, this is some very superficial looking at QOF data. And I wasn't allowed to animate it. So this is all the data for England, and each of the regions have been named and shamed. And this is knowing that we should have an estimated prevalence of 1 to 2%. You can see that London has the lowest prevalence of heart failure in the country. London's always had the lowest prevalence, and there are some people who say that's just because we have the wrong types of patients. That's not true. We're just not looking at it enough, and we're not recording it enough. There's lots of reasons, but it's not because we just have less patients who actually have heart failure. So I think this just proves that it is under-recognised in London. Look at the next slide. This is looking at some of the London boroughs. I think I've anonymised it. This was done quite quickly, and this is basically so this is the register, and I was quite surprised by this. There is a London borough that doesn't actually achieve a QOF register for heart failure patients, which I thought that was nearly mandatory. So I was a bit surprised by that. But then this breaks down again the prevalence. Third from the right, the prevalence is again broken down, and you can see there's quite a wide variety. The highest is about 0.7, but it goes all the way down to 0.44, 0.35. In fact, this is not very, very far from what we'd expect. So we're not seeing as much heart failure in London.
Well, probably a really helpful slide for us to think where we are. So I know 08Y is West London CCG. Afi and Simon, which is Central London CCG from that code?
I tried to anonymise it, but clearly failed.
It's very useful data.
I didn't want to name and shame.
To learn from.
Silent and shock.
Silent and shock. I mean, West London has the lowest prevalence, apart from 08C, whichever one 08C is. That's really useful for us to know.
Recorded prevalence. That ironically means you're doing worse.
Exactly. So it's to pick more up, definitely. So if everyone looks at their borough which they're in, I think that's fantastic slide, actually.
That's good to know. Ignore this page. If we go to the next slide.
Oops. Yep.
So this is just a very simple slide to say, if you think someone has heart failure, if someone's sitting in front of you and they're breathless and you're not sure it's heart failure, just do an NT-proBNP. Simon and Afi will talk to you about how easy it is to sort that out, certainly on system 1. It's part of what we've done. Do the blood test. If the blood test is normal, you know it's not heart failure. If the blood test isn't normal, you know you need to refer. And essentially in primary care, that's all you need to do. You can do more if you want to, but that is the very base thing that you need to do. NICE have set out that when you refer to me, technically I should then see a patient within 2 or 6 weeks, depending on that NT-proBNP, and I will see the patient with an echo. So if you sit there and you think it's heart failure, just do the blood test, and if it's high, refer. It's nearly as simple as that. Oh, sorry, I tried to fast forward. If you go to the next slide. So this is my last slide, you'll be pleased to know. So from my bias point of view, thinking about heart failure, when the patient's sitting in front of you, always think of heart failure if someone is breathless or if they're starting to fill up with fluid or if you're just not sure. Diagnosing heart failure is really important, and it's actually really easy to do. The NT-proBNP will rule it out if it's not heart failure. And obviously, if you are thinking it's heart failure, then please refer to your local heart failure cardiologist. Part of what we're doing across our 3 boroughs and alongside our primary care colleagues is increasing in terms of education. So not only are we integrating more and being more apparent and talking more with our primary care colleagues, we have weekly teaching sessions. We are working more integratedly, if that's a word, together. The working together has also opened my eyes a lot to what the difficulties are in primary care and how we can help make that easier for you, but also for you to understand how we work. And actually, for me, that's been a real benefit of this work. And Caris and again, Afi and Simon will very briefly touch on some of the digital applications of care that I think longer term will revolutionise how we work. So I think I'm going to stop there and hand you over to Afi and Simon, who will talk a bit more from a primary care aspect of what we've been doing.
Thank you so much, Carla. I think that was just really important for us to realise that, you know, we've got a lot more to do to pick it up, and when we do pick it up, we can actually reduce mortality and just really, you know, really hit home. So handing over now to Dr. Afsana Safa, who's going to talk through the new heart failure templates with Dr. Simon Gordon. Afi.
Thank you. Oh, actually, these are Simon's slides. There was a couple just before that.
Ah, they're the ones I couldn't find, Afi.
Yeah. If they can't, don't worry. This is all I was going to say. I can just say it. It's not too bad. Basically, it's just introducing Simon is what I'm doing. So to put this into context and following on from what Carla's just said, we put together, North West London put together a crack co-design team, many of whom you'll see today, and many behind the scenes who've been working on this pathway. And yes, we can talk about, you know, integrated care. We talk about what's right for the patient. We talk about reducing duplication, so the right patients are going to the right place, but that we say that every time we talk about new pathways. So what's different this time? What's different this time is that we firstly got together as it was primary care and secondary care in the virtual room together, as Carla was saying, mapping out the whole pathway from pre-diagnosis to end of life. And this almost like, I swear it was like the biggest process map I've ever seen. It was huge. And then from there, we identified 30 opportunities for change and improvement to the pathway. And we've started working, I think, on 6 or 7 of these, which is what you're going to hear forward. So it's really just to introduce the difference this time to this pathway as opposed to previous pathway changes. Thank you. I'll hand over to Simon.
Thank you. And actually, while Simon's speaking, Carla is answering questions in the live Q&A, so please do pop in your questions there for Carla.
So thanks, Afi. I mean, I think what I'm going to do is sort of discuss how some of the things that we came up with. I mean, the first thing that as a GP was the sort of combination, the issue between BNP and pro-BNP and which one should I be using? And, you know, the simple answer was just pro-NT-BNP. So now when you go into ICE, you will only find NT-proBNP. And I know as a GP myself, I've suddenly become a lot more mindful of it and testing of it a lot more. And then once you've got the diagnosis, starting last year, but not applicable, and now happening this year, is QOF is becoming a much more of an issue with heart failure. So we built a template around a similar design to what we had with the diabetes template. And what it allows you to do is not only code heart failure, but the type of heart failure. So once you've done that, you'll have a little star so that you can trigger the template going forward. And then what we did, what we're doing is we're building the specialist care system in a line to our system. So if you use this template and you're speaking to a patient and you press the heart failure care plan bit at the bottom, you will see in the right hand side what the specialist has done. So you'll be able to follow up easily on what everything is being, everything that's been going on. The other thing that people go on about us a lot is things like CMC. And we're always encouraged to do it, but we came to the conclusion actually is those conversations actually make a lot of sense to happen within specialist care because they have the understanding of the disease and what's going to happen. So they will also be doing CMC with us. We also looked at things like district nurses. We know that sometimes bloods need done. The specialists want to do the bloods. They send a message to us. Then we have to send a message to the district nurses. So we're basically smoothing that all out. They're going to be able to refer directly to district nurses to get things done. And the same for rapid response teams, which is in the process, so that if somebody is very ill, and to save them just dragging them straight into hospital, the specialists are going to be able to refer people straight to the rapid response team. And hopefully going forward, we'll be able to apply that to other illnesses and other pathways. Next slide. The templates are very similar to what you know in the past. We're just highlighting some other things that you may not be aware of. On the second page, if you want to prescribe medicines that you need for heart failure, you can just click the button and they'll come up automatically. Next slide. Referral forms, we've just made them as simple as possible. Essentially, you just bring up your pro-BNP and you tell them what happens in the consultation. Next slide, please. And discharge letters, again, all of what you've seen, we've sat down with various GPs who may be on the call. We've sit with patients as well. We've looked at it, we've had a think about it. We try and sort of tested things. And if you do feel that there needs to be improvements, tell us and we'll make it even better. Next slide. And then the last bit is heart failure care plan. Again, and this is part of QOF this year, and this will come up in a similar way to the diabetes care plans come up within System 1. And what we've made sure also is that patients are very aware of the heart failure team, that they have the number of the heart failure team, and they know that they can contact them directly. And that's what we've been doing.
That is an incredible amount of work going behind the scenes in the middle of a pandemic when we're all running around like headless chickens to have reorganised and integrated the pathway. And I can imagine all the GPs watching this are quite excited to actually go into System 1 and try this out. So any questions for Afi and Simon before we move on to discussing how we then manage our patients with this pathway with CARES? There may be a couple of questions that people haven't asked, but I think, is this going to be a consistent service for the whole of the tri-borough, so Hammersmith, Westminster and Central London? Is it the same referral in?
So that's a very good question. Right, so we are starting with Central London. The template, and if you guys, I guess a lot of you probably have System 1 in front of you, please feel free to sort of bring it up and have a play with it just now. But at the moment we're starting with Central London, and then once we've worked with Central London, we plan to spread it out further.
Okay, so in the meantime, we still use existing referral pathway for Hammersmith and West London, which is currently electronic route for West London CCG.
So for Hammersmith and Fulham have agreed to use the new referral template.
Okay, fantastic. Okay, it's really helpful. And then the other thing you said, that is actually when you go on System 1 here, you can see what the specialist has said. If the patient's been referred into St Mary's or the Hammersmith, is that the same? Is it integrating with the secondary care as well, or is it just in the community that we'll be seeing the notes there?
So if they're using Carla's heart failure service, which I think, you can tell me if I'm wrong, Carla, is essentially the tri-borough. Yep. Yeah. When you click the heart failure care plan bit, or you click the heart failure medication review, on the right hand side in the yellow, you'll be able to see, like many of us do with blood tests, you'll be able to see all the prior consultations on that topic.
That's fantastic. So thank you so much.
I think it's worth adding, it might be obvious, but obviously most of our heart failure clinics and my heart failure clinics sit in the community, so we use System 1.
So this is really exciting for GPs. And let's now move on to asking Caris. Oh, wow, Caris, how we can, how the integrated nursing service and remote optimization project is going to really affect our patient care. Over to you.
Thank you very much. Next slide, please. So as Carla has already said, we are a fully integrated service, and I think that's really important everybody understands that. I worked in many heart failure services in the southeast of England, and actually the best model is absolutely the integrated service. We have our 3 hospitals across the Tri-Borough area, 2 with A&Es and 1 specialist heart assessment centre. And as you rightly point out, we cover the communities of Hammersmith and Fulham, Central London and West London. Next slide, please. So these are your heart failure nurses. You probably come across their names on your letters often. There's myself as the nurse consultant and Claire Screech-Powell as the lead nurse. And these nurses all work in the acute sector as well as the community. So they're able to follow their patient journey from admission all the way through to the community. So they do really build up. That helps an awful lot with the transfer of information and care also. Next slide, please. So we do care for our patients from diagnosis to end of life, as Carla has already pointed out. We will discharge our patients once they are optimised and stable, because we know that GPs manage stable heart failure in the community very, very well. However, the trajectory of heart failure is very up and down, and you will have to refer back to us at some point in the future. However, we make this as easy as possible, and we give contact details to the patients as well, so they're able to self-refer themselves back in. With the self-care measures, if they feel that they're deteriorating their symptoms, they can just contact us and be referred straight back in again. So we make it as painless as possible. Next slide, please. So I just want to tell you why we need heart failure specialist nurses, and actually there's a terrible inequity of heart failure specialist nurse provision across the UK, and even less equity of the integrated service. So we are really, really lucky in our area to have this integrated service with so many heart failure specialist nurses. And I'll tell you why. There's been there was a huge RCT that showed that nurses made a substantial impact on the overall burden of heart failure. They limit costly admissions and they improve these patients' quality of life. We do reduce hospital admissions, and when we come to the remote optimisation project, it's important to understand that they do this really by optimising evidence-based therapies and education and self-management strategies, which is a lot about what our remote optimisation project will entail. Following that RCT, and that was back in 2001, it was calculated that if a specialist heart failure nurse service was implemented across 60 sites in the UK, there could be a net benefit of £20 million to the NHS. Furthermore, as if we needed more evidence after all of that, the British Heart Foundation did another study, and they found that heart failure nurses not only prevent heart failure admissions, but the programme demonstrated a 35% reduction in all cause admissions to hospital and all the savings that went with that. If you take nothing else away, please understand that patients under the care of a heart failure specialist nurse are 5 times less likely to be hospitalised, which is significant. Next slide, please. So that we know from the National Heart Failure Audit that heart failure nurses are considered in the audit as specialists if they see patients on admission. And we see an awful lot of patients in the acute sector, and we are blessed again, as I say, with nurses in the acute section in the hospitals as well. So we do see an awful lot of patients on admission. And the NHS long-term plan, actually, one of the very few lines we had on heart failure in there, did actually say that they did recognise the benefit of heart failure specialist nurses in the acute setting, because they were saying that they wanted to ensure that more heart failure specialist nurses saw patients that were not on cardiology wards. And the reason they say this is because the audit also tells us that patients that are not admitted to cardiology wards, they're sitting in outlying wards, may be not admitted with heart failure in the primary position but have heart failure as well. They don't do as well as those patients admitted to cardiology. However, if they see a specialist outside of the cardiology ward, their outcomes are much improved. So as I said before, especially in an integrated service, our heart failure nurses play a really key role from admission to discharge and onward referral. Next, please. So this is this wiggly line basically shows you the disease trajectory of heart failure. Normally what happens is there's a decline, we get them on therapies, they do quite well for a little while, then we have these peaks and troughs until that never quite recover and go into decline. Now these are the evidence-based therapies back from that RCT that nurses were able to prescribe back in 2001. So you can see that even in 2001 there wasn't a huge amount that they could do with therapies, but they still had a significant impact. Next slide, please. So you can see from 2021, we have a huge amount of therapies that we're now be able to administer to our patients. That means that they stay on our caseloads longer, but we do an awful lot more for them. So in actual fact, it's interesting to see that we can do so much more, but we're not actually increasing resource to manage this at all. Next slide, please. So just because I'm on, it's my slide and I get to brag, I just want to show you this is a recent paper as well that showed that heart failure nurses titrating medications compared to cardiologists, they did better, possibly because we see them more often and we can see them more regularly and we have more time to see them. So actually, again, just more evidence that we do a great job. Next slide, please. Your nurses are very highly trained. I won't go through all of this, but your nurses are expected, if they're not already non-medical prescribers, when they join us, we do put them through that training. So they should be able to prescribe all these therapies themselves to ease the burden on the GPs as well. Next slide, please. So just again, because it's my set of slides and I'm showing off nurses, heart failure nurses are amazing and they are super nurses. Next slide, please.
I think very inspiring.
Thank you. Next slide, please. Okay, so we're facing more challenges now. As Carla's already discussed, we've got this increasing prevalence with an ageing population who are multiply comorbid, but now we've got the impact of COVID. We've got a potential tsunami of heart failure coming our way. We've had delays in optimisation of guideline-directed medical therapy, and we know from the studies that patients that are optimised quickly and put on all of the drugs very quickly, then their outcomes are so much better, both from a mortality, morbidity and quality of life perspective. But we've had delays in this because we've had a reduction in face-to-face appointments. We've had reduction in admission to hospital with chest pain, MI, late presentation MI, so we don't know what's coming our way there. We've had a reduction of admission to hospital with heart failure, and again, there's various theories for why that might be, but where are those patients and when are we going to see them? They're coming our way now. We've got increasing therapies to treat, as I said before, which is amazing and fantastic, very exciting time for us working in heart failure. But as I said before, we don't have actually any increase in resource to manage these. So we need to find efficient, cost-effective ways to manage this increasing heart failure burden. Next slide, please. So one of the things that's come out of COVID, I think we'll all agree, apart from not just about remote reviews, etc., but you know, this is one of the positive innovations to come from the pandemic, something that would have otherwise have taken us years, we've managed to do in weeks and months now. So this brings me on to the remote monitoring and virtual reviews. Next slide, please. So this is a real whistle-stop tour of the Heart Failure Imperial Dashboard and the remote optimisation project and pathway redesign. What are we hoping to achieve? So Simon's already talked about some of this, as has Afi, and Carla's touched on it, but we have had reduced face-to-face appointments, which were high risk during the pandemic. So we are catching up with those delays, as I said to you before. And these patients are at risk from delays in diagnosis and optimisation of therapy. So we've got to see these patients quickly. We need to improve efficiencies in utilising healthcare resources. So this is important when we're talking about remote optimisation, because we can reduce estates and staffing, and that in turn reduces the associated healthcare costs. Again, timely rapid optimisation. This is something we're really aiming for with the remote project. We want to improve patient engagement and self-care. That's part of this project as well. And of course, we do know that patients that engage in their own healthcare goals have much better outcomes. One of the really important things that Afi was talking about as well was the increased collaboration across acute and community services with the pathway redesign, the template changes, the ease of referring to district nurses, palliative care, rapid response, etc. Those template changes may seem very simple, but actually it means that we have to bother the GPs a lot less because we can refer directly and quickly and get a quick response. Also for governance, it's all kept in the patient record, which I think is incredibly important. We want to improve the visibility of patient healthcare information across the care settings, and I'll come to that. And this remote monitoring that we're going to be looking at, and remote optimisation, we're hoping to improve the safety, reliability and enhance the remote assessment that we have been doing during COVID. We want the usual stuff. We want to avoid admission, and we want to reduce the unplanned contacts to A&E and to the GPs. And I think this is a really under-recognised one that's coming out from remote projects across the UK, and that's improving the quality of life and economic benefits to patients. Patients often have to take the whole day off work to attend appointments, or their relatives do. They might have to pay the £7.50 parking at the hospital or the travel costs, etc. If you can have your remote consultation done in 20 minutes and you're at work, you don't have to spend the whole day, it's going to be massively impactful on people's quality of life. Next slide, please. There are challenges. Some of the ones that have come up quite regularly are having blood tests done, remote monitoring provision, what's going to happen about the ongoing finance of the remote monitoring equipment, lack of objective physical clinical assessment. There are patients that we literally do have to put our hands on, and this is not going to be suitable for. And then we have the other one, which is the clinician and patient preference. Some people want to be seen, and clinicians often want to see those patients. We are social beings and we like that interaction with our patients, but none of these are insurmountable. Next slide, please. So I won't go into this, but as I said, not everybody's going to be suitable for this project, for the remote optimization project, but we have looked at risk stratification and it's fairly standard, I think. Next slide, please. So we've collaborated with a company called Lucy in the Netherlands, who are providing a remote review platform. Next slide, please. And basically, it's an application that's available on iOS or Android. The patients will be given Bluetooth devices, so they'll have blood pressure cuffs that can do their blood pressure, obviously, and their heart rate. And they will also be given the bathroom scales. They will be asked to. They will have individual parameters set for each of the patients, and when they take their readings daily, it will automatically go through, as I say, via Bluetooth to the app. Next slide, please. So this is what the app looks like. It will send you notifications in the same way that you would get for anything else on your phone. It will prompt the patient to take measurements within their own parameters, as I said before, and then the patient will it'll have to send them reminders to do so if they miss it. We have got bespoke education modules that we've done from the heart failure team at Imperial, so they are actually written by the heart failure team, and the patient can read those education modules at any time, but if there's a specific point in the patient's journey that we want to send them something we want them to look at, we can do that. Interestingly as well, we can see how long it's taken them to read it and whether they've completed them, so that will be interesting data to look at afterwards as well. We're looking at our patient-reported outcome measures because it's really important that we evidence the use of this and how well we're doing with it, so that we can either, manage it, tweak it, or whether, and keep it rolling forward. But we realise patients get questionnaire fatigue, so these questionnaires are being released at specific times during the patient journey as well, or as and when we require them. So, for example, a PHQ-9. All of this information appears on the heart failure dashboard, which the heart failure specialist nurses will be looking at daily for alerts, but they will also be looking at them when they do their remote reviews. The patient can keep the equipment on discharge, and they can use the app for self-care once they're off-boarded from our system. Next slide, please. So as I said, the nurses will be using this information for their virtual consultations. The information will be added into System 1 in the usual way, and the letters will be created to the GPs also. So it will be available as soon as the consultation is complete and saved. You'll be able to see it in the usual way on System 1. Next slide, please. So we understand that interoperability with our electronic systems is just universally panned and complained about. But we are looking to create interoperability with Lucy to System 1. So that's planned at the moment. So hopefully that will go straight through. We'll be able to get the information from Lucy straight onto the system patient's record in System 1. If we achieve this, that will then obviously go through to the WSIC dashboard. And hopefully we might be able to in the future create some kind of interoperability with Patients Know Best. But also when the patients are off-boarded, these Bluetooth devices will be able to interact with Patients Know Best as well. So this is all in the future, we hope. Next slide, please. So we are looking at our outcome measures, remote monitoring versus usual care. Don't need to explain that. Next slide, please. But what I'm saying is we do need to evidence what we're doing here. So I won't go through this slide necessarily, but these are the ways that you can refer from your various boroughs. Patients can self-refer, like I say, if they've been previously known to us. We are trying to take those obstacles out of the way. We take referrals from most healthcare professionals. The nurses will see patients that have heart failure with reduced ejection fraction, so less than or equal to 40%, but they will see patients with preserved ejection fraction if they've previously been seen by the heart failure consultant who gives them a management plan to do so. And we will provide home visits to those patients that are housebound. So next slide, please. So these are our contact details. I'm sure we can share these with you after the fact. Please, if you have any questions about patients, whether to refer, whether to not refer, patients previously known to us, if you want to change any medications and you're not sure whether you can because they're heart failure medications, please do contact us. We really don't mind. You can, we're there 9 to 5. You can leave a message or you can contact us via our team email there as well. Next slide, please. Okay, that's me done. Thank you very much for listening to me ramble on there.
Thank you, Caris. I think that was really inspiring, and I'm sure lots of our nurses listening are thinking about how they can get also more involved in maybe upskilling in this area and other specialist areas as coming in the chat. And I think that imperial.hfu@nhs.net line is going to be a lot busier going forward. I think lots of GPs have been wondering how to get in contact, and clearly, it's, as you say, it's really accessible, and you're there 9 to 5, and that's just really good to know. So we have now, between now and 2 o'clock, time to run through case studies and answer any more questions. Lots of questions are coming in as we speak. I'm just going to keep publishing them, and if you can maybe start with the case studies. And then we can get to the questions whilst you have a nice few more for us to get through. So I'll go to the next slide. Okay, so back to Carla, working with Caris. Tell us about Mr. Smith.
So this is me. I'm sorry you've got to listen to me again for a couple of minutes. So Mr. Smith, he's an 80-year-old man. He's contacted his GP because his legs are swelling. Of late, he's struggling to lie down in bed at night and he can't walk to the paper shop anymore. He used to be able to do it in one go, but now he's stopping 3 times. He's got a very typical past medical history for one of our typical heart failure patients: COPD, CKD3, type 2 diabetes, previous ischemic history, AF, and an enlarged prostate. Next slide, please. So on examination at the practice, he's got his BP and his heart rate are okay, but he's very tired. He's had chest auscultation, very quiet bases, no added sounds, though, no crackles through his lungs. He's got significant pedal edema though, and he's got pitting to below his knees. No chest pain, no palpitations, no dizziness or anything else. So it's really the breathlessness, the fatigue and the leg swelling. Next slide, please. So I just want to ask everybody, actually that animation didn't work. I was going to ask everybody what test would you order, but of course it's the NT-proBNP. This is absolutely, if you've got someone coming in, especially if they've got a previous cardiac history of any kind and they're coming to you with breathlessness or leg swelling, please do an NT-proBNP. Next slide, please. So again, I won't go through this too much because Simon's already shown it to you. NT-proBNP is, you can request it directly on System 1. Next slide, please. And these are the results. You've helpfully sent him for a chest X-ray. It appears enlarged with small bilateral effusions, ECG, AF, nothing too much there, wide QRS. His kidneys are not great, but his NT-proBNP is seriously elevated at 2,200. Next slide, please. So what would you do next? I think probably we'll have to move on from that, won't we? But have a think about what you do next. Next. So start freezamide. It's really important that you try and offload this gentleman before he gets seen by our heart failure consultant and for his echo. Next. Consider starting Ramipril and refer to specialist heart failure service. Next slide, please. So here we are on Referral Wizard, System 1 here. You can click on this button, next slide, please, and that will bring up the referral form that Simon showed you earlier that will hopefully mostly auto-populate to make life easier for you as well. Next slide, please. So he's referred to the heart failure service, the referral's received, he's triaged to the 2-week pathway, echo booked, reviewed by heart failure cardiologist afterwards, And this echo shows that he has an LV ejection fraction of 25%, so he's got severe LV dysfunction. Mr. Smith is started on guideline-based therapy and refers to the heart failure nurses for education and optimisation. Next slide, please. So he's offloaded by the nurses, he's seen by the nurses in the clinic, his medications are optimised. It's limited a little bit by CKD and symptomatic postural hypotension. So he's got a potassium of about 5.4, EGFR is now sitting on the 30 and slightly low BP, but we don't worry about a low BP like this unless they're really feeling quite symptomatic with it. And we don't worry about that potassium either. However, he's symptomatically improved and we've got him on all the therapies we can, and we discharge him back to the GP with this lovely discharge letter that Simon showed you earlier that will give you all the reasons why we haven't gone any further with medications, etc. And the heart failure specialist nurse contact details are provided to the patient and the GP should there be a deterioration in symptoms. Next. So these are his drugs on discharge from the service. He's on sacubitril valsartan mid-dose, bisoprolol, furosemide. We've added dapagliflozin. He's on his metformin as before, tamsulosin, warfarin and inhalers. Next slide, please. So what happens next? So he's not under the heart failure team anymore, goes back to the GP. GP does routine bloods as requested and the potassium's 5.7. The out-of-hours doctor calls the patient and stops sacubitril valsartan to reduce the potassium. This is a really common scenario. Mr. Smith starts to feel breathless. His legs are swelling. He attends A&E and he's admitted with decompensated heart failure because he's now not on anything to prevent him from decompensating. During his admission, he has a hospital-acquired pneumonia, luckily not COVID. And he's in hospital for a really long time, 14 days. On discharge, he comes back to the heart failure specialist nursing team, and we have to restart the optimisation all over again. But we're unable to reach the previous doses of evidence-based therapy. As I say, this is a really common scenario, and once they've come off their meds, my experience is that it's often very, very difficult to get them back up to their previous doses. Then that's going to result in poorer long-term outcomes, increased morbidity and mortality risk. If you have someone like this and you're concerned about their heart failure medications, please contact us first via those numbers or via the email. And if you have to do it over a weekend, contact us and we will get, and you have to stop something, contact us so that we can actually instigate them again as soon as possible. Next slide, please. Over to Carla.
Thank you, Cara. So there's a question that's come in that I was just looking at. Perhaps you can answer that. There are, of course, no contraindications to requesting an NT-proBNP. It's a blood test, and I'll let you answer that. I have some very simple questions, and if anyone wants to answer in chat, I would be very grateful because otherwise I end up talking to myself. So very, very simply, just several clinical scenarios. I will be as brief as possible. So this is a gentleman that comes to see you in clinic. He's known to have an idiopathic dilated cardiomyopathy. He's been stable for years, and he comes to you for a yearly checkup. Mild COPD, mild renal dysfunction, creatinine of 128, and diabetic. Very typical of most of our patients. He's on good medical therapy. Or reasonable medical therapy, Rampal 5, Bisoprolol 5, and he comes in for a routine medication check and mentions that his blood pressure, that he's a little bit dizzy on standing. It's only happened once or twice over the previous day. He's never collapsed. There are no other alarming features. Oh, sorry, next slide, please. So you do his blood pressure, lying and standing blood pressure. He doesn't have a significant postural drop, but those are his blood pressures, heart rate's normal. So the question is, what do you do next? I've written at the bottom here what he was on. So 5 and 5 of bisoprolol and ramipril. Given his history of dizziness on standing the previous day, and given these blood pressures, would anyone make any changes to his drugs? If I could have, I would normally ask for a show of hands, but if some letters could go in, I'll wait for like a second and talk to myself. And if not, we'll go to the next slide. So we'll go to the next slide because No one seems to be answering.
That's exactly what I was going to say, Carla.
Thank you. Yasmin, actually, I might have to use you and abuse you, so you're going to be my guinea pig.
So, oh no, I was joking. I'll go back on mute.
Tough luck. It's too late. So you are now my guinea pig. So yes, I would do nothing. So his blood pressure is not alarming. If you go to the next slide, I've got a few just notes on blood pressure. One of the things that people sometimes get very anxious about is low blood pressure. Because these drugs make such an impact on patients' quality of life and their prognosis, the attitude of the heart failure team to blood pressure is largely, we really don't care what the blood pressure is, so long as the patient isn't very symptomatic from it. And what I mean by that is a little bit of dizziness is not exciting. They need to really, if there's a faint or if they really can't get up and about because their dizziness is that bad, then that is fine and you may reduce the drugs. But if it's just because the numbers are low, that is not a reason to reduce their prognostic heart failure therapy, just because the implications of doing that are massive. So I'm fairly aggressive. It's one of the reasons, I guess, that patients will come and see myself and Karis and our colleagues. Is so long as the blood pressure is above 90, I will continue up titrating. So long as they're getting blood to their brain and their kidneys, it's fine. The other obvious thing, of course, is that if they're on any other blood pressure lowering drugs, then stop those in preference for the heart failure prognostic medications. So if we go to the next slide. Mr. AT is back. He's a very unfortunate man. Having decided that the Ramipril doesn't need to be reduced, you undertake the yearly blood test that requires, so his usernees get repeated. So if we go to the next slide, his baseline creatinine is 128, but on the usernees that come back, his creatinine's now gone up to 142 with that potassium. So again, Yasmin, on the basis of that, what would you do? Would you increase or decrease the Ramipril, do nothing, or increase or add in some spironolactone?
Goodness, I'm gonna hand that one over to Simon Gordon.
Oh, Simon's to this.
I hope that so one of the things that I've learned is that we tolerate creatinine.
Yes.
So I would do nothing.
Oh no.
Or are you going to?
If we go to the next slide.
What was the question?
What,
yeah, we tolerate or increase. Sorry, I didn't know what his blood pressure was.
Oh, okay. To be fair to Simon, he's probably doing what I did whilst Karis was talking, and that is something else.
You got me.
But he's right. We do tolerate the creatinine, again for exactly the same reasons. Now there are clearly limits, but 128 to 148 really unexciting. So if we go to the next slide. Now, I know that the world has moved on since when I trained and everyone is now talking about EGFR. I'm afraid I've not made that transition, so I'm still creatinine based. But Yasmin, if we go to, okay, fine. So I will talk about creatinine in a moment, but that Simon or Yasmin, whoever answers this question, that should give you a clue as to what I would like. So this man in clinic, I would have continued to titrate his Ramipril. You look at his notes and it's exactly the same man. He's a bit breathless on walking longer distances. His NYHA class is 2. So he's not entirely asymptomatic, but largely asymptomatic. The notes say his last echo was about 5 years ago. That was the last time he was seen in the heart failure clinic because EF at the time was 40%. So if we go to the next slide, the question again is, what do you do? So you've got a gentleman with a known dilated cardiomyopathy. EF was 40%, but that was looked at and done 5 years ago. Not currently in the heart failure service because 5 years ago he was entirely stable on good drugs, and he's come back and he's still stable, but it's been 5 years and he is still a little bit breathless on longer distances. So the question is, what would you do? Do you go, actually he's been stable for 5 years, wonderful. Do you get an up-to-date ECG? Do you get an up-to-date echo? Do you refer him back to the service? Or do you just say, fine, look, I'm going to increase the Ramipril, hunky-dory, I'll see you again in a year's time? Simon or Yasmin?
I mean, I'm assuming you'd always want to have an up-to-date ECG annually anyway, wouldn't you, heart failure patients, just to monitor them? So
you're right. So if you press the next slide, I've actually said that all of these are correct. You are correct. So NICE stipulate yearly bloods, so full blood count, usernees, LFTs, TFTs, ferritin and TSATs, and a yearly ECG on all patients, stable or otherwise. Everyone should get all of those. The up-to-date echo I only really do if symptoms have changed or if we've finished up titrating. So I wouldn't do a routine echo, but it has been 5 years. So, you know, you might consider one. The big thing here is quite a lot's changed, as Karis has said, quite a lot's changed in the last 5 years. We've got wonderful new drugs that we never used to have. And frankly, if he's not got a normal heart and he's still a bit symptomatic, he actually qualifies to be switched from Ramipril to Sacral. He can have the dapagliflozin added. There's so much that we can possibly do. So if this is a patient that you have on your books who's been stable but actually hasn't been seen, and you feel that actually we could squeeze some more into him, then by all means refer these patients back. They don't have to be, you know, dying at the front door. So I
don't mind me saying, Carla, I mean, that's one of the sort of learnings for me, is that there's a lot of new things that we don't know about, and you guys have got a lot of new things developing, and sort of squeezing a bit more out of them is something that you can also do. And one of the interesting things that we sort of keep picking up on is that you know, people coming out of A&E often get medicines being stopped, and we're sort of left a bit managing that ourselves, and that you guys are sort of very, you want to sort of help them, and sometimes you're not aware of what's gone on in A&E, so that they might need fed back to you by us.
Yes. I'm just answering because it's along the same line. So someone has asked about cough with an ACE inhibitor. And so actually, if someone really has an intolerant cough to an ACE inhibitor, that again is a reason to send them back to us. Whereas before I wouldn't much worry. Actually, we would switch these patients now to sacubitril valsartan because it is superior to an ACE inhibitor. So if you can't tolerate what used to be the gold standard, there are better drugs now that we can give. So that's sort of a patient we would see, re-look at, and then consider switching to an ARNI. So the very last one, if we go to the next slide. So I'm very aggressive with renal function too. There are very few occasions where I'm very, very, very concerned about renal function, and that's specifically in patients who are very sick, who I'm thinking about heart transplants. It's the only time I am very, very, very careful with renal function, because the only way you get a heart transplant is if everything else is pristine. If you're not qualifying for a heart transplant, then you just have to treat the heart failure as much as you can, and we will tolerate a degree of renal dysfunction. It is much better to have renal dysfunction and a better heart than a little bit of both. There's a lot of evidence to show that, in fact, heart failure patients with normal kidneys are far more likely to die earlier than patients with slightly abnormal renal function. So if we go to the next slide. And
actually, it's just going 2 o'clock now, actually, so I wonder if we can't go through that case study just now.
Yeah.
And just maybe if you guys, I mean, I've learned so much from that. I've just been making notes as I've been going along, but if you could just summarise maybe your key learning points for our audience. Most of the questions that have been asked have been answered in the chat, so if anyone wants to read those answers, that's they're really helpful. But maybe just summarise the key learning points in the webinar. We could stay on potentially after 2 and just go through that slide, but just I'll hand over to you both.
If this slide, if you put it onto the next one, that's the answer, and I think that's all you need.
Maybe that was me hoping we wouldn't be quizzed anymore there, Carla.
Keep going. Just go on to the next one. It basically come up to the questions and give the answers. It's all about HFpEF. It's fun. Very quickly, someone asked about AV block pacemakers. So there is evidence that a pacemaker, a dual chamber pacemaker, can cause LV dysfunction, but it's very common. But it is why people will get a CRTP sometimes instead of a dual chamber pacemaker. But it's not common. Ironically, I've been emailed about a patient who needs an upgrade purely because of pacing induced LV dysfunction. It is a thing, but it's not common. Okay, I'm not going to talk about HFpEF. So Yasmin, I don't know if anyone wants to ask any questions or type any questions. Oh, you wanted some take-home things. Sorry. Take-home. Integrated care is the way forward. I have learned personally more than I actually thought it was possible prior to meeting and working alongside Simon and Afi. I have a newfound respect for I always respect what GPs do, but I didn't quite appreciate some of the difficulties, the practical difficulties that you have. I'm hoping that we've addressed that. I feel that we have for where we are, and I'm hoping that we can translate this wider scale. Specifically for heart failure, drugs are really good. Don't stop the drugs. Please contact us. We're very happy to be spoken to and contacted. And largely, I'm going to have to paraphrase this, but largely I don't really care what the renal function is or what the blood pressure is. within reason. And I'm going to let Cass got a hand up, so I'm going to shut up and let her talk.
I just wanted to say, when we were talking about prevalence, for example, one of the important things and the under-recorded prevalence, we are really happy to come out and provide education sessions to GPs, to practice nurses, to look at your patients, to look at your QOF, and consider register reviews and things like this in the future. We are, do contact us. We're very approachable and we're really happy to work with all of you to improve that for you.
So thank you all so much for that update. I think that does transform a lot for primary care. I can see lots of changes happening for our patients, especially we get the real message out there about how accessible you are and how we're really going to be doing this together going forward, and using all the new systems to integrate that care and get our patient care where it needs to be. We're going to be sharing the slide pack. If you can fill in the Menti meter as usual with your email address, and we will circulate it as usual from the training hubs. And send out the video. And for those of you who couldn't attend today, so we know there was a meeting clash with another GP meeting, do circulate this to your colleagues. The video will come with the slide pack. So thank you to our speakers. It was absolutely fantastic. I think we will definitely have to have you come back again, if that's okay, maybe later in the year. And it'd be lovely to see the update as well on how the pathway is working in Westminster, and to be alert as to when it's been then going to be expanded even further into Triborough and out of Triborough. So thank you very much. And the next webinar, I should remind myself, the next webinar is coming up in 2 weeks' time, and we'll be covering CKD. Again, our Imperial College specialists, and this will be a North West London wide webinar, and same time, same place in about 2 weeks' time. We'll see you then. Bye-bye.